Then of course
money
everyone
alone
and
is about
so they
$4
are
billion.
building
And
towers,
NGOs
right?
are beginning to
Telecommunication
tap
towers as well.
Oh,
Typical
like
industry
Dr.
in
Bollinger said, a
healthcare
lot of people are
education
doing a
world.
lot of things. The idea is to, and originally what Mo is, and that's why I kind of brought Mo here, is this whole idea of collaboration. Because the synergies have to be looked at, you know, and that's what we need to start working on. You know, so many places are, multiple resources are going into areas that if we work together, we can streamline, be more efficient, and deliver, you know, have a better delivery.
Thank you. As you can see, 15 minutes goes by very, very quickly. Our next speaker is actually going to be on the phone, so if you'll give us just a quick moment to do some audio-video change-up. Do you have his direct number? We'll dial him on the conference phone. This is not a break. Please don't leave.
Come back. Good to see you. There we Sorry, I missed the first half of your talk. No, it's okay.
Seen you a long time. Missed few meetings.
Yeah, we just won a
This
huge
mic
grant
should
for my
be open.
tech nonprofit in the U.S. You guys later see where that's good news. Hey, Sonia.
Okay, go ahead, Tricia.
Hello,
Yes,
Jingraji, you are on.
okay.
Thank you.
Okay, back on. I'll give you a quick introduction, Dr. Dingra. So our next speaker has been in the pharmaceutical industry for 25 years and founded a 501c3, the Dingra Family Foundation, which is dedicated to supporting primary education, sanitation, and hygiene education, and vocational training for underprivileged children. And so they've worked with Pratham and Ekla Vidalia for the next 10 years. Please give a big round of applause for Dr. Om Dingra. The floor is all yours, Dr. Dingra. Thank you.
Good morning. Can everybody hear me?
Can we get the volume up a little bit?
Yes, sure. Yes, please continue.
Okay. All right. Good morning, everyone. I'm really sorry I could not be there in person. I'll try to do my best. And
Oh.
Hey, push the button.
I guess yeah, that's I guess the input more.
Where is he?
North Carolina.
Hurricane hasn't got there yet.
Gosh, some clouds.
We'll have you back in a second.
Okay.
Are you still there, Dr. Dingra? Hello?
hello?
Okay.
Yes.
Sorry about that. We kind of went offline there for just a moment. So if you don't mind starting over, please, that'll be fabulous. Thank you.
Are my slides up?
Oh,
Yeah, we're going to have them up for you in just a second.
Okay. All right. Good morning, everyone. I'm sorry I could not be there in person. And I'll go through the presentation, and then if there are questions, I can answer at the end. First slide, please.
Yeah, yep, we've got the first slide up.
Okay. So, Tiffin organization focus is making videos on sanitation and hygiene. And they have made 3 videos and used well-established Bollywood stars so that there is a lot more impact of the videos. And they are shown on Indian TV. When you get a chance, you can go on the website and watch these 1.5 minute videos. So it will give you an idea of the topics we are trying to cover: TB, malaria, and just bagging of the garbage. And Dhingra Family Foundation, as was mentioned, our focus is on education and sanitation hygiene projects. Next slide.
Okay?
Okay. So our aim is to improve sanitation and personal hygiene in India by increasing awareness of the linkage of poor sanitation practices with common diseases. Unless people understand how current practices cause diseases, they will not change their habits. So it's very important for them to see the connection, how not washing hands before touching food transfers the germs from the hand to the food. So unless they see and how those germs then cause various diseases, it will not stay with them, stick with them. So it's very important for them to understand the connection between diseases and poor sanitation practices. And we want to implement simple disease prevention practices and demonstrate their effectiveness in reducing disease levels at pilot scale. And then expand the program to all of the 54,000 acre schools of the successful pilot program. Next slide.
Okay, we got it.
Go ahead.
Okay. So this slide shows causes of common diseases which most of you are familiar with. I won't spend too much time with tuberculosis. Mostly if you carry germs and spit around, they are airborne and infect everybody else. All Indians test positive. Even though but we all test positive and we come into this. Sometime we have to take antibiotics for 6 months if we get tested. And mosquito-borne diseases, everyone is aware of the chikungunya epidemic we have in Delhi right now. All hospitals are full of chikungunya patients. And every year, either dengue fever or chikungunya in India is a major problem. Fecal-oral contamination, again, these are diseases which originate from contamination of water. Everyone is familiar with plague, rodent-borne, and then airborne, again, asthma, pneumonia, and TB. So these are all diseases really linked to poor sanitation and hygiene practices in India. So next 3-4 slides, I won't spend too much time. You are all familiar with the current situation. So is access to sanitation slide on the screen?
Yes.
Okay. So without spending too much time, as you can see, India is at the bottom of the list. 69% of rural folks and 18% of urban folks do open defecation. This is 2008 data. Things may have improved some, but they haven't seen that much. Next slide.
Yes.
So this is again World Health Metrics 2009. Again, you can see India is at the bottom with the, if you pay attention to the stunted growth, which typically results from poor sanitation and hygiene as well as nutrition, you can see greater than 5 years old, 47.9% of the people are stunted. So if you compare Western growth of same families who have migrated here versus their brothers and sisters who live in India, you will see a tremendous difference in the height as well as well-being of boys and girls born in this country versus in India. So this can be prevented by improving sanitation and hygiene. And again, the diarrhea death, all-cause mortality is very high in India. Next slide.
Okay.
Yes.
So, again, on this slide, without spending too much time, health and economic cost is very high. And as I mentioned earlier, most of the sickness in India are a result of poor sanitation. And their eradication will save big money to families. Next slide.
Yes.
So this is the older slide, but it communicates the point I want to make. The cost of various diseases resulting from poor sanitation. So you can see diarrhea is the most expensive one. In early childhood, that's where most of the kids get 25.5 billion. This is 2006 cost, so you can imagine the cost now where the population is. So similarly, you can see malaria, measles, sarcoma, and respiratory infection and intestinal one. Next slide.
Yes.
So this is again the diseases and the cost for each of the diseases I showed on the previous slide. And the biggest impact is on tourism. So unless we improve our sanitation hygiene, in addition to the poor health of our population, tourism is impacted the most. Next slide.
Yes.
So, as I mentioned earlier, the root cause of most of the diseases in the whole world is dirty surroundings and bad hygiene. So, teaching good sanitation and hygiene will result in reducing levels of common diseases. So, for example, in US, we do not give prevention vaccines for cholera, typhoid, and medicine for malaria because these diseases have been eradicated. Lately, you may see one or few cases of malaria when people from other countries infected have traveled to US. So CDC immediately announces that as soon as they see even a single case. So people are sometimes under the wrong impression that the slums outside their boundary walls of their homes don't impact their health. They are equally prone to be attacked by same mosquitoes and germs as poor slum dwellers. So even if Ambani can make $2 billion building in Bombay, it doesn't prevent people living there from the same diseases which all the slums around the city. So mosquitoes and germs do not differentiate between rich and poor. Next slide.
Yes.
So what is being done? Of course, everyone is aware of the Swachh Bharat Abhiyan, which Modi ji launched since he became Prime Minister. Even there again, it will take time to have impact. But a lot of ministers and others, they have photo ops where they are holding the broom, but if you go and talk to people around there, nothing is happening. in remote areas, especially and big cities. So what the impact will be will only time will tell. And Ministry of Rural Development has been focusing on sanitation for last 20 years. Same thing is true of the National Urban Sanitation Policy, Ministry of Urban Development. These programs have been in place for last 20 years. And multiple NGOs, of course, are working on clean water, running hospitals, clinics, free eye camps. What is needed is simple, next slide.
Yes.
Simple, affordable practices to improve sanitation and hygiene and ensure that water is not infected, food is not infected, air is less polluted, walkways and streets are clean, elimination of flies, mosquitoes and mice. So these are essentially where we need to focus to prevent these diseases. Lot of focus has been on treatment rather than prevention. Next slide.
Yes.
So focus areas for awareness education. Again, as I mentioned earlier, education on germs, presence on everything. These germs cannot be seen, but they cause diseases. So hand washing practice before touching any food is critical. Similarly, anti-littering campaign, main cause of dirtiness and increase of mosquito population as well as mice. Bagging of the household garbage in plastic shopping bags. And in villages, they can use the organic waste to form compost and use as manure. Again, next, how do we get fecal-oral contamination? Public defecation and urination ultimately gets in food and water. That's it. So spitting spreads the tuberculosis. How do we get mosquitoes and related diseases? Dirty surroundings bring in mice, mosquitoes, and diseases back in home.
We have 1 more minute, sir.
Okay. I may need a couple of more minutes. So, again, education on justice and hygiene is key. So our thinking is that we increase awareness of equal teachers by sharing information on relationship of common diseases to poor sanitation, develop and share educational materials including videos, help implement simple practices to improve sanitation and hygiene, train teachers to educate, mentor and monitor. Next slide.
Yes.
Using Foldscope is a simple foldable microscope, and it was invented about a year ago by Dr. Manu Prakash at Stanford. And just 2 weeks ago, he received the MacArthur Foundation Genius Grant, which is about $625,000 grant for 5 years. It costs $1. You can see bacteria and amoeba. You can go to the website and see the Foldscope and its application. Next slide.
Yes.
This is how the Foldscope looks. It essentially uses the origami principle of the Japanese art. So this is essentially a flat made out of paper. So you can read about it. People all around the world are developing simple applications for Foldscope. and it was distributed to 137 countries. And India also is using it to develop applications. Next slide.
Okay, thank you. 30 seconds, sir. Thank you.
Yeah. So next step was that Media Foundation is working on developing simple experiments to demonstrate how simple sanitation and hygiene practices get rid of disease-causing germs. Hand washing, dirty nails, water sources, beaches, barefoot walking. Next slide.
Yes.
So future plans are to run a pilot with April Vidyalaya to train teachers in the use of force soap along with sanitation hygiene posters in schools. And details of these experiments will be provided. Children will be encouraged to explore experiments and then share those with their parents and siblings. Next slide.
Yes.
Thank you.
Thank you.
Thank you very much for that presentation, Dr. Dhingra. What we'd like to do is open it up to 2 questions from the audience. So if you feel you have the best question, now's the time to offer that up or ask that. See a question brewing. Or do you
How
have
about
a
the second best question?
The second best question? Okay,
People were intimidated.
Okay, so Dr. Dhingra will make sure that we check out your website at chipin-inc.org, and he's got some videos there, and if we have some time at the end of the day today, we'll play some of those videos for you. And other than your website, is there any other way for people in the room to connect with you, sir?
Yes, David. I mean, I can leave my phone number. Shashiji has my phone number.
Okay.
As that there is a Dhingra Family Foundation Facebook. So if you put in Dhingra Family Foundation, you will see all the projects we are funding in India on Facebook.
Okay, perfect. Thank you. We'll check out your page on Facebook, and we do have a question in the room.
So,
Okay.
yes, sir, that was a very, very nice presentation. So I was intrigued by you are using the Foldscope both as perhaps a diagnostic device, but also as a device for social change by providing it for children to go home and experiment with. And that's very exciting. I wonder if you had some other ideas around things to catalyze social change around this issue of sanitation.
Yeah, we are trying to see how simple things can be done. Foldscope is one. But again, we are trying to develop a catalog of simple things which can be essentially cause social change. What we believe is that if we want to bring social change, it is our future generation. So we really need to focus on children. And they are the future of the country, anywhere in the world. So anything we develop, if we show it to children, it will stay with them for their life, and they will share with their family and others. So the focus has to be on developing simple tools which can be used to bring social change in any area. Health and hygiene is one. And just even how to equally treat girls and boys, those type of changes and can also be brought through simple teaching at elementary primary education. Thanks for the question. Excellent question.
Thank you.
Good, excellent. Thank you so much for that question. I think that concludes our questions. Let's give Dr. Dhingra a big round of applause. Thank you very much, Dr. Dhingra. We're going to hang up the call with you. Thank you so much.
Okay. All right.
Okay, and we're going to resume back here in a moment. Okay, great. How are you doing? Everyone
You're
okay?
awake, I think, right?
You're awake, you're enlivened by all this innovative stuff that's going on all over. Fantastic. Well, we're going to continue the innovation train here with our next speaker, who's going to be talking to about an IntelliCare health kiosk that's in Kolkata. Please welcome our next speaker, Dr. Sumyadipta Acharya.
Thank you. I can do this or this.
If you have the USB stick, they'll hand it over to Dr. Bellinger. He'll take it over.
I've got a Mac, so we should be fine.
And if it's okay, he'll just run the slides for you from there.
All right.
Perfect. Thank you. He's well qualified to do this, I promise.
Yeah, minimum qualification. Getting tenure at Hopkins. No.
You need a.
Well, while that comes up, let me introduce myself. I'm Shomo Acharya. I'm the graduate program director for the Johns Hopkins Center for Bioengineering Innovation and Design. And we're a center within the biomedical engineering department. That's me, the last guy over there. A couple of my students, former and past. Former and present, I mean. And our center is a translational wing within the biomedical engineering department. Part of what we do, in fact, a major part of what we do is focus on appropriate low-cost technologies that are intended to have a global health impact. So we work with field partners in various countries, identifying, understanding needs, and then iteratively working with groups of public health professionals, clinicians, designers, and engineers, several of whom are from the student body. We try to come up with solutions, test them in baby steps, create more evidence that this seems to be well grounded in what the customers, what the patients, or the doctors need, and then kind of take it forward. So today I want to share a story about IntelliHealth, which is our it's a project that a group of 2 generations of my graduate students have worked on for about 2 years, and it was just recently spun out as a technology nonprofit, and it got selected to a very prestigious incubator at San Francisco, known as the Fast Forward Accelerator. They were there at Google and BlackRock, and from the whole tech nonprofit community, just eye-opening. I was there a couple of times, and it's just a very different world. Anywho, next one, please. So just by way of context, this project is about access to comprehensive evidence-based primary healthcare. And the problem, most of us in the room know that 70% of population in India, as an example, lives in rural places, whereas only 2% of doctors actually practice there. So there's this huge access gap. The barriers to care seeking are the time, the cost, and the distance, the cost, and the time. This kind of leads to the stitch in time saves 9. So people typically in rural areas will put off seeking care till such time that the symptoms cannot be avoided anymore. And therefore, what could have been mitigated by a simple primary care intervention oftentimes ends up as a tertiary care, higher burden of disease. So we heard a lot today about preventative measures. There's been a lot of very good things going on in how do you do health promotion, disease prevention sort of activities, and that is actually the mainstay of a lot of public health interventions. We're kind of going one step after that. So let's say you are experiencing some symptoms. What do you do when you're here? You go check out with your physician, right? You go to your primary care provider. Someone sitting in rural India does not typically have that access. And the care choice is kind of animated, so you can kind of maybe go through to the end. Yeah, this is, all right, that's good. So there's the care choices. Primary health center, as per Government of India since independence, every couple of villages has a primary health center, then there are subsidiary health centers. And the problem is they're free, but they're poorly equipped. And honestly, the quality of care oftentimes is very dehumanizing. So if someone does travel and get there from 6 villages away, it's not the best care that we're looking for. There are secondary or tertiary private clinics, highly skilled providers, but they're of course expensive and mostly city-based. Then there's the government tertiary hospital system, typically in cities and smaller towns. And patients, as I said, after they avoid that stitch in time, when they do get to the city, it's again a very it's an opportunity cost as well as a fairly dehumanizing cost. You're experience. You're standing in line for 2-3 hours, and then you get to see the doctor all of 2 minutes, and that story comes back to the village, and therefore patients keep avoiding. And then of course you have this huge body. I think most of you might be aware of this so-called rural medical practitioners, the unlicensed underbelly of India's healthcare providers that pejoratively refers to as the quack doctors. So they're not doctors, they're typically associated with the healthcare system in some ways, maybe a pharmacist assistant somewhere, maybe an OT technician somewhere, go back to the village and start just practicing non-evidence-based medicine. You come in with some symptoms, and the usual therapy is a concoction of corticosteroids and antibiotics. So it's a very dangerous sort of way in which care is being accessed by, and unfortunately that's the only access that oftentimes patients in these villages have. They are well-meaning. We have interacted with several hundreds of them, interviewed them, understood their persona. So it's not like they're ill-meaning, but they just don't have the training, and the government does not recognize them. But that's another story for another day. So the quality of care is a lack of availability of expertise because doctors don't live in villages, lack of resources, I kind of being repetitive here, and the patients seek quality care. I don't know what's over there. So we asked the question, so we could maybe animate down all the way, yeah. We asked the question, can a substitute in a village be used in place of the doctor? How do we use the resources available to build an appropriate solution? And can the system deliver quality care? And this is very important to our charter. That's ethical, evidence-based, dignified, and affordable for patients. So we basically set out on a journey of, to put it simply, a telemedicine-enabled delivery of comprehensive evidence-based primary health care. And we took a slightly non-traditional approach. We were not, of course, the first people to think about it. There are organizations like World Health Partners, eHealth Point, who have attempted these with varying degrees of success. The challenge oftentimes has been this ability to scale, because they oftentimes depend on very resource-intensive capital equipment, as well as the availability of high bandwidth internet. So 4G, 3G is not available. They will typically have a VSAT connection through some sort of funding. Therefore, that naturally does not scale financially. And one of the things, we're a group of designers, so we're engineers and designers, and one of the things we realized with all of these models, unfortunately, with all due respect to them, is typically these were not created, with a deep customer immersion. People did not. These were designed by very well-meaning doctors and policymakers sitting around tables in New Delhi and New York. And with all due respect to them, it was very well-meaning. But what ended up happening, as we have seen, is there was probably not adequate attention paid to the patient's own value perception. What does the rural patient want? The health worker who is going to run these clinics, what drives her? What are their pain points? You can't just impose technology on them. And then we're talking about doctors, when we're talking about telemedicine, some doctor in the back end. Can we really recruit and retain doctors who want to do this for a living? Is there a persona of a doctor who can do this well and with confidence? So those are the very early stage hypotheses that we started testing with a very design thinking sort of approach to this. Yeah, and this is kind of some nice eye candy from a couple of clinics that were started by one of our partners with the technology that we developed. This is in a rural place in Birbhum district at the border of Jharkhand and West Bengal. This is a clinic in the Sundarbans. Sundarbans is the delta of Ganges. It's home to the Royal Bengal tiger. And this island, Bali, where we started, it's about 30,000 people, and not a single hospital, not a single doctor, no electricity. So we kind of challenge ourselves to see, well, if we're doing it grounds up, let's just go to the most godforsaken places that you can find and see what we come up with. Otherwise, you're probably designing for something that's not scalable. So let's move on. So the needs for telemedicine for a comprehensive care model is that we need to collect high quality clinically relevant information in an autonomous fashion, conduct high quality clinically relevant physical exams, and provide the patient with a meaningful interaction with the doctor using minimally available infrastructure. What I mean by this is, when I talk about high quality clinically relevant information, right? If I'm a 55-year-old male coming to the primary care physician with acute chest pain, the doctor has has a set of diagnosis, hypothesis in mind. And the next question they ask about the nature of the pain and aggravating factors, those are all kind of tuned towards expanding or reducing down that list of hypotheses, going from a list of differential diagnosis to some provisional diagnosis, right? And therefore the sequence of questions, the symptoms you elicit, is a function of the medical knowledge and training and experience. So is it with the physical exam. So when a doctor is then embarking on a physical exam, it's also very hypothesis driven to reduce down that set of possible diagnoses. this cannot be emulated by a health worker who has a education to the level of high school and has probably received 6 months of additional training. Short of putting them through medical school and residency training, you can't expect them to ask the relevant questions, right? So most health systems that are in operation, most telemedicine systems that are in operation right now, use a video link to get a doctor to do that live. And the doctor's time is expensive. That, if you amortize it that way, it doesn't become financially sustainable. So that's kind of a sneak peek, and I'll tell you what we did with it in just a bit. Then similarly, you cannot arrive at more than 50%, or, you cannot arrive at a meaningful therapeutic plan in most more than 50% of diseases unless you have some sort of physical exam being done. We realized that very early on when our partners started testing this model. So could you train the health workers, like your Arogya Sevikas, in a certain subset of physical exams that they could safely and effectively do, and that the doctors in the back end would be confident about? So for example, if I went to medical school in my past life, so if I were to report to my attending that the liver is enlarged, my attending, probably wouldn't believe me if I were a medical student. It'd kind of be doubtful if I'm a first-year resident. and by the time I'm a fellow, they'll say, all right, I trust you. I don't even need to palpate the liver anymore.
But
So,
there is nothing wrong in dying with that. That will solve many other problems. Population increase and many others.
well, that's an interesting take, but
Really?
so we came up with a subset of exams that the doctors felt they could safely and effectively rely on. Next. So that led to IntelliHealth. It's a telemedicine platform based on the OpenMRS, which is a world's largest available open electronic medical record system. As the back end, as the front end, we have a knowledge-enabled telemedicine platform. About next one, yeah. Just some comparison between some existing things that are out there. Some of the things I wanted to highlight is that we have what we call job aids. So what questions to ask is driven by a knowledge engine. What physical exams to do, you pop up the right multimedia tools at the right moment, how to check for pedal edema, how to look for jaundice, so that it reinforces their training just in time. It's also very low bandwidth friendly. We do not require 3G or 4G. In fact, if we have minimal internet, it works because the entire doctor consultation is dependent on phone, and it's open source implementation. All right, how it works. Let's go on. So when a patient comes to a health worker, there's a list of symptoms from which they can choose. There's a back-end knowledge base, so exhaustive list of presenting complaints. Based on what presenting complaint or complaints the patient says, go to the next one. You can go to second or third level questions, like you have difficulty in breathing. What brings it on? Exertion. Is there any chest pain associated with it? Any other associated symptoms? Kind of emulating the logic, the medical knowledge logic, which has been codified, and also evidence-based. It's been codified from Harrison's Principles of Internal Medicine using teams of doctors here at Hopkins as well as in India. Go ahead. And then, of course, followed by an adaptive set of physical exams. All of this the health worker is doing autonomously. Go ahead, next one. So we've covered up until now in our prototype about 35 common symptoms, 385 associated questions, 69 physical exams. Next one, Bob. Just kind of run through this and go ahead. And then at the end of that consultation, so an intelligent knowledge engine works on a simple mobile devices. A back-end doctor sitting in Kolkata is then receiving the history note and the physical exam note and the patient's details, and then they are engaging in a phone conversation where the doctor's time is optimally used. The doctor has already arrived at 80% of what the diagnosis might be. The 2 or 3 or 5 minutes the doctor spends on the phone is quality time spent on explaining the therapeutic plan to the patient, eliciting some more important symptoms, and then dispensing a therapeutic plan as an electronic prescription that gets printed out at the clinic. And the clinic, of course, has a pharmacy in a backpack model, some low-cost diagnostic tests and all of those things to supplement. Next one. Yeah, so this is, I think, we're ending the near of it. So maybe it's animated, we can go forward. Yeah, so on the rural side, there's a completed patient note, which is a history and physical exam note done autonomously. The remote doctor receives a call, sees the patient details, that's evidence-based. And then there's a consultation with the doctor on the phone without requiring video or anything at all. So we have realized that voice phone lines, even on the cell network, are very reliable. Internet is not. So that's how it emerged. Next one. and then a fill-in prescription. So IntelliHealth is this is animated slides made by students, which I particularly am not a fan of. IntelliHealth is a software platform. And so our positioning is that we ran an experiment for the last 2 years. We think it's fairly successful. Our partner, NGO partner, has now seen upward of 2,000 patients with this in the last 2 years. Patients are charged about 40 rupees just to test the value hypothesis, if not anything else. And they come back. They come back with family, they come back with their neighbors. And which is, sort of testament to the fact that they are perceiving value in what they're getting. And they are receiving, and the doctors we've recruited in the back end, where we experiment with multiple persona, and the persona that seems to work the best is the retired professor of medicine who has time in hand, who is willing to work through the quirks of an early stage system with some bugs, who is an educator at heart and therefore can educate the health workers as well, and have that sort of a little bit of a professorial attitude towards them, so that they're taking the health workers under his or her wing. That has worked out wonderfully. And then they have the wealth of experience that they are able to deal with rural patients of all literacy levels. Very, very nice. So IntelliHealth is a platform, I think that's next. So IntelliHealth is a platform, it's an open source initiative that we have been chatting now for quite some time, I guess.
Sorry. That was my instruction. Go ahead.
Very nice.
So chatting quite some time now with the Arogya Foundation to basically try and see if this makes sense for your initiatives. What I know about Arogya, what I've learned about ACL is that you guys, of the many things you do, one of the things you do is run health camps. And I oftentimes have seen these, and my kind of discussions with Dr. Bhatia, and Dr. Bhatia has visited these clinics, by the way, was that when you have a team of well-meaning doctors who are donating their time, and you have this wonderful infrastructure of Arogya Sevikas, could we have a higher impact than we can by just doing health camps? Health camp meets a certain need, but it doesn't meet the daily primary healthcare need of a population. When you're down with a fever and intractable chest pain, you can't wait for the health camp 2 months down the line. So could this be redirected in a way where your Arogya Sevikas are actually delivering value every single day in the population that they serve? This doesn't have to be a clinic model, it could be a backpack model, it could be a room in a school sort of a model. So we've been chatting with your organization for some time and hoping that we can do a pilot sometime with your organization, and if it pans out, and the purpose of the pilot is to design this to the skill level of the Arogya Sevikas as well as to the necessities of your organization. And then if it works out, then see how we scale. Last word I would say is the beauty of this is extremely low capex. So it's based on a tablet, $75 tablet. We have additional sensors like a low-cost ECG device that's been developed in-house, a whole bunch of things. So the capex of this model is very low, and it can scale very rapidly. But one needs to see if it, So that's kind of what IntelliHealth is. These are some of the health workers from Sundarbans, the island. They walk actually about 1.5 hours to get to the clinic. There's no motorable roads. Very dedicated young ladies. And it's been a wonderful journey for our students and as well as for our partners in India. And now we're ready to kind of expand our footprint beyond them to other organizations and to other geographies. So thank you.
All right. Was that amazing or what? Please give another round of applause.
If you have a moment for any questions or anything, happy to answer, or now or during lunch.
Do we have anyone who would like to ask a question or two?
Just one really quick question, sorry. Sorry for coming in late, by the way. The remote doctor side of it, is that accessible on like a mobile device,
Yes.
smartphone or whatever?
Yes.
So they can take it wherever they are, take that 2-minute, 3-minute call?
Yeah. And we learned that the hard way, because the remote doctors, since we're not paying them beyond the honorarium, sometimes they would be, in social visits. So they were trying to access the web page on their phone. So we said, might as well design it in a way that they can access
So it's
it
an
in
app. It's an
multiple
app.
devices. It's not yet an app, it's on OpenMRS. We will be developing an app, but OpenMRS has a mobile version, so on your mobile phone, it shows up differently. Kind of like the mobile version of New York Times.
So it's a website, but it's optimized for a mobile
Yes.
device.
But our next step over the next 6 months is to make a doctor-facing app as well.
Can I have a quick question? I have written PhD thesis on MRI. And these machines are so expensive. Why we want to put there? Let the whole, as it is there. Very difficult to afford all over India MRIs.
Well, I don't think, we were talking about MRS, which is medical record system,
Yeah.
not particularly.
All right, excellent. So we're going to go on a break in just a moment, but this is our chance to check in, right? Check in with yourself. And what we're going to do is go around the room. You get one word. How many words do you get?
One.
One. Let's try that again. You get one word. How many words do you get?
One.
Some of you, it's been a while since you've been in school, right? So we'll try that repetition. It works well for adults as well. So we're going to go around the room. One word. How do you feel right now?
Interested.
Interested.
Amazing.
Amazing.
Quite pleased.
Two words.
You have to break the rules.
That's a B+.
It was hyphenated,
Curious.
Curious.
I'll use intrigued.
Intrigued.
Thank you.
She can have 2 words. It's exciting.
Exciting. Okay. Art, good stuff. We'll take a wave.
He made up for the other words. Happy.
Happy.
The future. Right? Optimistic.
Optimistic.
Excited.
Excited.
Good. Learning.
It'll be.
No?
Inspired. Intrigued. Going.
Informed.
Tickled.
Alright. So here's what we're going to do next. We are going to be taking a break for 10 minutes. How many minutes? 10. That's U.S. time, in case you don't know what. 10 minutes. So the break will be timed. There will be soft, classic Bollywood music playing. That's how you know you're on break. The last 20 seconds of break, the volume will go up. That means please come back to your seats, right? So please remember the facilities, if you need them, are down the hallway at the end. Make a right. There's still snacks and coffee in the break room. And enjoy your break. We'll see you back in 10 minutes. Thank you.
Can I trade cards?
Yes.
We're actually in fast forward too. Did you know
man.
Michelle and Darcy? We're in it just now.
Come on, yeah. Oh, I loved her talk. Oh my God, what a fascinating young lady. The 2 young ladies yeah, she was actually the first speaker on demo.
Right, exactly. Yep, you remember. Good.
I was there. Such an impression.
Well, I love what you've done. It's awesome. I can't wait to hop on with you after I show my presentation. Awesome.
Yeah, Kamal is amazing. And what a powerful story. I mean, she starts her tale with, as a 7th grade teacher in Mississippi. I remember, see? That's the amount of impression. And this is the classroom we had. And I told Neha that, look, you guys did a fantastic presentation, but learn from that very much. That's the one you should benchmark against.
We need something now.
She's very good at.
For a little bit. It's Ashtami. Actually, yes, my family is. I'm supposed to meet them at some point.
So we definitely need to have a conversation.
Yes,
I've been talking to Dr. Bhatia. I talked to Rosie. I'm trying to train them to be doctors. So we need to.
Yeah, I was recently in a call with Sabina ji and Rajan ji. Probably just I think 2-3 days ago. And we just need to do it.
Right. So what they're.
Which segment?
I have a better appreciation of some of the hesitations, which might have been from a budget.
Yeah.
Exactly, that's where I was.
And what I tried to
That's what I
point out
got.
to them was that 90% of that budget was expenses that we think your operations will incur, which is, cost of doctor. Now, if you have a different cost of the doctor,
Recently took a turn.
knock that out. Your doctor is a volunteer, so those are not our budget at all. So I think now in JHU02 they understand, and I would say
They
that's where
used
the
to be
holdup.
affiliated with sort of
Yeah.
Hopkins.
And the holdup is the resources. So that's where I kind of got into a conversation. So last conversation I had with Remy is we have a project for me.
There's no,
and it's not a lot of money.
So
From
that
our
is so you
I never cut, I just spoke to him like 2 weeks
I
ago.
guess a lot of it you'll have to
But
look at it and see from
I
our
was
side.
never quite clear what his business was.
But on your side, I believe you had a proposal, something that he does give, but we're interested in that. The proposal I saw was a kiosk proposal. Is there a proposal for the portable remote?
It's a lot of big
It's all
data
kind of
stuff.
instant. So it's modular in the sense that if there's something that we suggested might be the cost of bricks and mortar.
Right, that's what you had
Cost
suggested.
of cost of the table, cost of the chair, cost of the
I think it was 25,000.
right. So and that's ridiculously high in any case.
Exactly.
So if you have
That's what kind of threw us off.
but it's your cost, right? So you guys, Rajan and Mukherjee, look at it and say, hey, we have these small schools, a room in a school costs us nothing, or a room in a village rent is really 1,200 rupees, it's like $18 a month or something like that. And then we're going to get some furniture or not. Our recommendation was when you do the pilot for the first time, in order to
Integrate
get
with
it right
any
for
big
your
NCI
organization, that
networks.
we do the first one where we have some sort of a clinic where the patients can come, because there's some benefits to that. And what we can experiment with is if we have, let's say, 4 ROG saving us, or 6 in that clinic, then maybe 3 of them are on staff on a given day, and the other 3 are doing the community outreach sort of things, where it's a mixture of same kind of
Actually, no,
healthcare
you're not gonna be
using
there.
the tablet, but also preventative
Make sure you're
care.
comfortable.
So going door to door, collecting demographic data, anemia surveillance.
I know a little bit about it, not only
stewarding,
from Neil, but
hygiene
also
education, all those things, which can also be done through this platform very easily.
Now, when they go into the remote, is that an offline, the data collection, or it has to be
In
online?
India, yeah, it can be offline. But in India, there is seldom any villages other than the remote northeast where you don't have even 1G. You do have 1G.
You run into situations,
Yeah. I mean, in single ones, for example, we run into that where it's down, internet is down.
He wasn't feeling well, but he also
It
had a
wouldn't
new
matter
grandson.
because they can do all of this stuff offline.
Stepping away from
And none of this is dependent on high bandwidth internet. Voice is on the phone.
And his daughter got
We are actually also working on,
family
you
issues.
saw how the history notice, it's a branch.
He just actually gave us a big
We're trying
donation
to index it
to
as a
mobile
kind of an
clinic,
index.
TV
It's a little bit of technical detail, so that the actual text doesn't need to be transmitted. It's only an index number. So you can transmit the entire history note as a single encrypted SMS to the server. The server unpacks that and presents the history note to the. So even when internet will be
It's based in
down,
Pune, but
we are working on a model where if internet is down, then it goes as an SMS. So the SMS packet network is different than the data packet network.
he's been very.
But listen, we've been talking for a while. We should, and at the Fast Forward Accelerator, the team was able to do some fundraising. So some of the cost sharing from our end can also happen. But there are some actual costs on your end, which is you're going to have to train the RSA guys, you're going to have to pay the doctors. You have to account those in, and that's why we put that fee. Please do think about these. Those are not our costs, they're your costs. And you guys have been in the healthcare delivery business for a while, so you can rush, rationalize, and optimize. That's why I was. And there are some costs on our end, like Neha and Amal have to go to the field. Rajan said that they can stay at so there you go. Let's make it happen. Let's make a pilot
So
happen.
let's take the next step, which what I'll do is get Rajan, Acharya, and Dr. Mukherjee, a group on a call. And I want them to make sure,
Keep me honest.
Let's at least initiate one pilot. I'll have it change more. Summer probably start.
Yeah, and we have a playbook almost where, site selection parameters also we recommend. We've learned that also from our experience the last 2 years. So, there should be certain things that are there. Like you shouldn't be right next to a big hospital. It doesn't make sense, right? So go to places there where the healthcare infrastructure is really challenged. There's a whole bunch of things. And we've discussed this actually with people just. So the other aspect would be training. So your RFK Sevikas will need some additional training on bedside manner, on dealing with the tablet. It's a very useful, very simple interface that health workers are able to use. But then additional things like bedside manner, physical exam. How do you elicit epigastric tenderness? How do you check for abdominal lumps? How do you place the step? These are actually, they might sound daunting, but it's not. I mean, it's a week or so of good retired doctors.
Right, I know, I talked about Dr. Bhatia, and he's more than excited to do this. The question is now it's in Delhi. Delhi has to look at the funding aspect of it. So that's where the hiccup is right now. So we need to talk to
You
Delhi.
guys are like government officials.
We are.
From Bengal to there, Rajasthan to Delhi.
We are. Remember, we got 55,000 villages we're working with. There is a bureaucracy. There is a bureaucracy.
Yeah, so we think like a 10 to 14 day session might be enough to get this started.
Incorporate into the civic training.
Yeah. So what I was thinking is Dr. Mukul Bhatia has some curriculum.
I know. We know the curriculum very well. Yeah.
So, you know the curriculum. All right.
We have
And
to
you
add
feel
on to that.
comfortable enough that they come with some certain background.
See,
And then you can build on it.
that's kind of the purpose of the pilot as well. To learn, like you never know. As designers, we always say you never know till you actually do it. So the purpose of a controlled pilot is also to learn about the comfort zone of your RFK Sevikas. What aspects of training to emphasize more, what less. So we should not finalize everything and then we should just do a pilot where even in the initial 2 months or 3 months, maybe even actual patients are not being seen. Maybe there's an actual doctor on site. But we're running it on a mock basis, mock quote unquote mock, so that the RFK Sevikas are doing it at an elbow distance from the actual doctor. Then your health system, there's regulatory compliance expectations also, right? The RFK Sevikas have to have a certain level of competence before you can say that, okay, I'm diagnosing epilepsy in this patient or myocardial infarction, right? Can't be cavalier about it. So I would say, let's take that approach. Our best estimate right now is anywhere between a 2 to 4 week additional training. Should be enough to get those started. But if we go in, let's try. And we always will modify that. So you have the 2 or 3 senior doctors who will be the trainers. They will modify it based on, this is what the beauty of having retired senior doctors are. Like when they realize that this is the aspect that needs more training, this needs, they're okay on that.
And the doctors will need to provide.
We will need some professorial type doctors. I told Mukul this also. You can't just have practicing doctors. You need to, at least for your initial pilot, you need doctors in the back end.